You also can ask questions to any speaker, but especially to the last one, Bernard Cholley, Hôpital, Européen, Georges Pompidou from France. The screen is yours, and stay with us for the final question and answer after the talk.
Good afternoon, dear colleagues. My name is Bernard Cholley, and I work in Paris at the Georges Pompidou Hospital. In the next few minutes, we'll talk about the management of right ventricular failure in patients with ARDS. First of all, there are many reasons for patients with ARDS to have right ventricular failure. One of them is that there is, due to the disease, microvascular obstruction in the lungs. This microvascular obstruction can be due to pulmonary capillary coagulation, but also to pulmonary vasoconstriction. And this vasoconstriction results from hypoxia. This is a hypoxic vasoconstriction. And also because there is an imbalance between endothelial factors regulating vasodilatation and vasoconstriction, and this imbalance favors vasoconstriction. Because these patients are frequently ventilated with so-called protective ventilation with low tidal volume, we allow hypercarbia, and hypercarbia promotes pulmonary vasoconstriction. In addition to that, when the disease is pretty much advanced, there is also remodeling and loss of capillaries in the lungs. All these factors contribute to the increase in pulmonary artery resistance. In addition, ventilation itself produces a burden on right ventricular ejection, and there is a cyclic increase in right ventricular impedance with each inflation in these patients. We also use frequently high PEEP in combination with normal tidal volume, which may result in overdistension of the lung. And if this does not produce the expected effect, which is reversing atelectasis, this will result in increased afterload as well. All these factors contribute to right ventricular failure, which will be first manifested as a dilatation of the right ventricle as a consequence of the increase in right ventricular impedance. Because of this impedance to right ventricular ejection, ejection is prolonged, and therefore the right ventricular end diastolic pressure is greater than the left ventricular end diastolic pressure, and this produces the paradoxical septal motion. Through ventricular interdependence, and because of this paradoxical septal motion, left ventricular ejection is also impaired. And therefore, the cyclic increase in right ventricular impedance due to insufflation results in reductions in stroke volume from the right ventricle, which are followed by cyclic reduction in the left ventricular stroke volume. These changes in stroke volume will induce variations in systolic arterial pressure, but this variation in systolic arterial pressure with ventilation is not due to preload dependence, but reflects afterload dependence of the right ventricle. This is an example of a patient with a largely dilated right ventricle and paradoxical septal motion, representing the ultimate stage of right ventricular failure called acute cor pulmonale. This patient exhibits variation in his left ventricular stroke volume. And as you can see on this picture of the recording of the aortic flow velocity in the left ventricular outflow tract, there is a decrease in left ventricular stroke volume that is very large, more than 50%, occurring following insufflation. We are measuring stroke volume in the left ventricular outflow tract, and therefore there is a delay with respect to insufflation, because this represents a delay that is required for the blood to transit through the lungs. There are a number of risk factors that have been identified to develop acute cor pulmonale in patients during ARDS. In a large cohort of patients with ARDS, Mekonso de Sap and colleagues identified driving pressure greater than 18 centimeters of water, PaCO2 greater than 48 millimeters of mercury, a P/F ratio of less than 150 millimeters of mercury, and pneumonia as a cause of acute cor pulmonale. Interestingly, in this cohort, plateau pressure and PEEP were not independent risk factors to develop acute cor pulmonale, but all these patients were ventilated with protective ventilation, and care was taken to avoid high plateau pressure and high PEEP in these patients. Otherwise, it seems clear that a very high plateau pressure greater than 27 centimeters of water or high transpulmonary pressure is certainly a risk factor for the right ventricle, as well as a high PEEP. PEEP has a dual behavior. If you do not provide enough PEEP, there is poor lung aeration, resulting in increased pulmonary vascular resistance. And if PEEP is too high, there is alveolar distension, which reduces the diameter of the very small capillaries around the alveoli and also results in right ventricular pulmonary vascular resistance increase.